name is Chris Delos-Reyes, addiction psych at University Hospitals. Very happy to be here. My patients love telemedicine because they get up, they're in their pajamas, they're smoking, they're vaping, they're petting their dogs, playing with their kids. So my patients love it. And since I have patients that drive into Cleveland from Sandusky and Burton and Norton and all these other places in Ohio and Medina, they love it because they don't have to get in the car and drive. So yeah, and most of them have pretty decent Wi-Fi. So except T-Mobile, terrible. So anyway, had horrible problems with my patient with T-Mobile the other day. So she was annoyed and I was annoyed because we couldn't even hear each other. Anyway, all right, so let's talk about some of the most common mental health concerns of people with opioid use disorders. We'll look at some epidemiology and management, and then talk about the role of buprenorphine as a novel antidepressant. If you guys can check me and let me know if my audio is good. I had a lot of problems with my audio. Thank you. I had a lot of problems with my audio, and I realized it was a bad set of headphones, so I threw those out and I'm using my gray ones instead of the white ones. Okay, so the first thing is that most of the people that walk into your office are going to have some level of anxiety and depression. So you can just sort of count on that. And so the question for you as a practitioner is to figure out, am I dealing with post-acute withdrawal syndrome, which we call PAUSE sometimes, or you might see it called protracted withdrawal in the literature, or are you dealing with something else? So to me, that's sort of the first fork in the road. Is this post-acute withdrawal syndrome, or is this a primary psychiatric disorder? Now, obviously, people can come into your office with any level of psychiatric illness, but in terms of people with opioid use disorders, you're typically going to see depression, anxiety, and a lot of personality disorders. At least I see a lot of them in my practice. So let's start with post-acute withdrawal or PAUSE. So this is an interesting phenomenon. It's not in the DSM-5 that I know of, but boy, it's everywhere in the addiction literature. And so this is the types of symptoms that can last anywhere from 2 weeks to 2 years after you've gotten off of alcohol or other drugs. Now that's a huge span of time, 2 weeks to 2 years. Just as a rule of thumb, the symptoms are going to peak over 3 to 6 months. And so what I tell my patients, especially if they've been using, say, for 10 years and they've never not used for a very long time, I just sort of teach them, like, look, you're coming off of these drugs. Yeah, you've been using drugs for 10 plus years. You're not going to feel like yourself, and that's probably going to last for 6 months. It might even last for like a year until you start to feel normal, whatever normal is. And so when the patients come in and they say, oh, I have mood swings, I'm anxious, I'm tired, I can't sleep, I say, that's your body getting used to not having those drugs there 24/7, and you're going to kind of feel like crappy for like 3 to 6 months. And so one of the reasons that our patients relapse so frequently in the first 3 to 6 months is because they're trying to treat their post-acute withdrawal and they want to go back to the drug that made them feel better. That's the only coping mechanism that they had for 10 years. So imagine, I feel like crap, so I know what to do. I'll use heroin, or I'll use alcohol, or I'll use whatever. So they go back to their usual thing to try to help themselves feel better. And of course, it helps them feel better temporarily because they're treating the protracted withdrawal. But then in the long run, they don't feel very good. So how do you manage post-acute withdrawal? With lots of encouragement, education, and the things that I've listed on the slide, which are things that all of us can do for health when we feel crappy and we don't feel good, right? So balanced diet, exercise, rest, relaxation, realizing that this is post-acute withdrawal and you have to be patient and taking very good care of yourself. That's how you manage it, okay? So if it's not post-acute withdrawal, then it could be something else that you see here on this slide. And this slide is basically some epidemiology about the interplay between substance use disorder and mental illness, and then vice versa. So the take-home point is a substance use disorder greatly increases your odds of having a mood disorder, and having a mood disorder increases your odds of having a substance use disorder. So I like to call it peanut butter and jelly, because where you see one, you usually see the other, right? So peanut butter and jelly kind of go together. So do mental illness and substance use disorders. So that's kind of how I like to think about it. So I got almost every single one of my patients is peanut butter and jelly patient. So the way that you read this chart is, let's look at the first column. Um, if you have alcohol dependence, that increases your odds of having major depressive disorder by almost a factor of 4, which means that if you have alcohol dependence, you're 4 times more likely to have major depression than somebody that doesn't have alcohol dependence. So that is how this chart works. So let's look at right here, 13.9. If you have a drug use disorder, such as opiate use disorder, you are 13.9 times more likely to have bipolar disorder than somebody that does not have a drug use disorder. So that's how you can start to see that, wow, this stuff is really, really common in my patients that have alcohol dependence and other drug dependence, okay? And then the opposite is also true, or you could say the converse is also true, that if you have a mood disorder, that also increases your prevalence of a substance use disorder. For example, if you have a diagnosis of major depressive disorder, then your chances of having a substance use disorder is doubled compared to somebody that does not have major depression. And if you have major depression, that is actually associated with a higher risk of suicide, worse substance use outcomes, and more severe psychiatric symptoms. Again, not unexpected. And then if you have the diagnosis of bipolar disorder, then your substance use disorder is increased by a factor of 4. So you're 4 times more likely to have a substance use disorder than somebody that doesn't have bipolar disorder. And then you could also see anxiety disorders. The same thing is true. If you have any anxiety disorder diagnosed in the last year, about 1 in 8 people will also have a co-occurring substance use disorder. So that's about 15%. And then if you look at lifetime comorbidity, so for all of your patients that have ever been diagnosed with generalized anxiety disorder, half of them are going to have a comorbid substance use disorder. And in particular, the diagnosis called social anxiety disorder, a fifth of them have lifetime comorbid alcohol use disorder. So it's very common to see social anxiety disorder sort of hand in hand with alcohol use disorder. So, okay, so just in terms of the stuff that you will hear patients say, I wish I could see everybody's camera at once. I can't do it in this view, but I'd say raise your hand and tell me how many of your patients have complained of mood swings. Because for me, it's like all of my patients have said, yes, Dr. Chris, I have mood swings. So my first piece of advice to you is please ask more questions about the mood swings. Don't just write down on your paper, mood swings, oh, this person's bipolar. No, they may not be bipolar. So ask a couple of questions about the mood swings, such as, how long do your mood swings last? So the patient might say, oh yeah, my mood goes up. It goes up for 5 minutes, then it comes down for an hour, then it goes back up for half an hour, then it goes back down for half a day. That's not a bipolar disorder mood swing, most typically, right? So if you have a mood swing and it only lasts 5 minutes to 2 hours, it's very unlikely that you have a primary mood disorder. There's probably a couple things that you have going on. You probably have something called a substance-induced mood disorder. So, right? So as your person is talking about mood swings, my other question after asking, well, how long does it last is, well, when you're having these mood swings, are you either withdrawing from your drugs or using your drugs? So then that sort of tells me, yes, if it's in the midst of them using, it's probably a substance-induced mood disorder as opposed to anything else. So the other thing that happens to people that have these, very quick mood swings, like 20 mood swings in a day, I start to think about a primary personality disorder, like borderline personality disorder, because there is a name for somebody that has those really severe, intense mood swings that only last a few minutes to an hour at a time. And the term for that is called affective instability, which is also known as intense episodic dysphoria. So basically in psychiatry, if somebody walks into the office with mood swings, it can either be substance-induced, it can be affective stability, or it can be part of a primary mood disorder. So those are the 3 things in your differential diagnosis. So please keep those things in mind. And all those three things are quite different from each other. They have different ways of treating them, which is why it's important to make the correct diagnosis. So what's the take-home message in terms of like a person that comes into your office with psychiatric symptoms is please don't ignore it. So on the one hand, I don't want you to withhold psychiatric treatment simply because the patient is using drugs and alcohol. So if you know the person's an alcoholic and they're drinking every day or they're drinking every other day and they're trying to get sober and they say, hey, I think I need some help for my depression, you know, the take-home message is yes, try to treat both of them, but also you want to teach them that, heck yeah, I can treat your depression, but if you're still drinking a six-pack every day, whatever treatment I give you for depression isn't going to work very well because you're taking in copious amounts of a central nervous system depressant. So that's when I get into that conversation with people that, you know, I need you to be honest with me, tell me how much you're using. And if you are using, you know, uppers and downers, that's going to lessen the effectiveness of any medicine that I'm going to give you. And most patients can get that. They can understand that whole point. And so they start to get the point that if they want some help with their anxiety and depression, they really are going to need to let go of the drugs and alcohol. So and then I always try to follow people rather closely and monitor them for the effectiveness of the medications. And so by closely, I mean more than like once a year, right? So sometimes I will see a doctor say, hey, here's 25 milligrams of Zoloft, here's 11 refills, I'll talk to you later, good luck with your depression. That's not how I treat depression. 25 milligrams of Zoloft, I'll see you in 2 weeks, I'll adjust the dose, I'll see you in another 2 weeks, I'll adjust the dose, and so on and so forth. So I kind of do it like how I'm doing Suboxone, which is if I'm putting you on Suboxone, I probably want to see you every couple of weeks till I get you on the right level. Same thing for the psychiatric medicine, you know, because 25 milligrams of Zoloft isn't going to do much when I'm trying to hit 150 or 200 milligrams of Zoloft. So that's, you know, and I can't put somebody on that right away. It's too big of a so, so I'm always telling clinicians to treat both disorders simultaneously if you can. So for the person that also has that co-occurring substance use disorder, I want to make sure that they're in the right level of care, that I'm using motivational interviewing, and I've got them on the right anti-craving medication. And so, and then again, always looking at suicide risk, getting them to a mental health professional if they need that, and how severe their mental illness is. What we do know is that what we have studied the most is alcohol. So we do know that antidepressants are more effective than placebo, particularly in alcohol-dependent patients that have depression. So you can have an impact on an alcoholic that's depressed by treating their depression. What we don't have as much clear evidence is in cocaine and opioid-dependent patients. So you got some of the data that's mixed. So, but if you do choose to go down the path of giving a person a medicine for a depressive disorder, again, as in most of psychiatry, the serotonin drugs are the first line treatment. And again, just my advice, you got to make sure there's an adequate trial. So do you have a high enough dose for a long enough time? So 25 milligrams of Zoloft for 2 weeks isn't going to cut it. You got to get up to 150 or at least 100, and you want to be dosing that for a minimum of 8 weeks. It can take you a while. It can take you 4 months to get where you want to get to. And that also is very important when you educate the patient. Like, you're not going to feel better with the first pill that you take. Anybody that feels better with the first pill that they take of an antidepressant, that's the placebo effect. That is not the effect of the serotonin. That's the effect of somebody giving you something and saying, hey, you're going to feel better. And guess what? You feel better. That's the placebo effect. So the other thing to note is that, again, we have more data on alcohol, but if you have a type B alcoholic, which is the early onset high severity drinker, the serotonin drugs are less helpful in that type of person. But interestingly, what is helpful in that type of person is Zofran, which, as you know, is the anti-nausea drug. So who knew, right? So if there's an adequate trial of, well, that's off-label, but if there's an adequate trial of a serotonin drug that fails, I will move on to a serotonin norepinephrine drug like venlafaxine or duloxetine. And again, sometimes I will move to Wellbutrin or Remeron, sort of switch classes. What if the person has, bona fide bipolar disorder? If you primarily treat addiction medicine in your practice and you don't feel comfortable with treating bipolar disorder, by all means, get them to a psychiatrist. So a couple things that we know in an alcohol-dependent patient, for example, that is bipolar, we know that lithium plus Depakote is superior to lithium alone. So that's one thing we know, is that typically if you have an alcohol disorder, you typically need combination treatment for your bipolar disorder. In fact, most people with bipolar disorder need combination treatment. It's a tough thing to treat. There are a lot of open label trials in people with bipolar disorder as well as substance use, and the open label trials have looked at Lamictal, Depakote, gabapentin, and Topamax. So I've definitely used all 4 of those drugs and in various combinations with my patients. There is limited data right now on second generation antipsychotics, so-called mood stabilizers. That's the drug companies call them, so that they can sell them to more people. So the drug companies and their mood stabilizers like Abilify and Seroquel and oh gosh, there's so many of them, Rexulti and so many new ones, and co-occurring bipolar disorder and substance use disorder. Oh yeah, Vraylar is the other popular one these days. So everybody's trying to push Vraylar, Rexulti, all these interesting things. What about anxiety disorders? Well, you're going to be like, hey, this is like a broken record. Did you talk about serotonin drugs? Yes, I did. But the serotonin drugs are also first line for your anxiety disorders. Whether your anxiety disorder is, PTSD, generalized anxiety disorder, panic disorder, or social anxiety disorder, it doesn't matter. SSRIs are still the first line. In particular, if you're interested or you're a stickler for FDA labeling, then you'll know that sertraline, which is Zoloft, and paroxetine, which is Paxil, are actually specifically indicated for the treatment of post-traumatic stress disorder, whereas some of the SSRIs are not. And venlafaxine or Effexor has, I don't know if it's the best drug, but it has the best marketing and research department, because they've got absolutely an indication for everything in the DSM-5. Kidding. But what they do have an indication for is generalized anxiety disorder, panic disorder, and social anxiety disorder. They're indicated for everything. The other drug that is not a serotonin reuptake inhibitor, but does work on the serotonin system in the brain, is Buspar or buspirone, and that is effective for generalized anxiety disorder, but typically ineffective for someone that's got severe panic attacks or social anxiety disorder. So I tend to save the Buspar for people that have generalized anxiety disorder, which is like chronic worrying all the time. It's like your nervous Nelly person. So okay, what about the benzos, right? So that's what the patients want. They're like, oh, Dr. Chris, I need that drug. It begins with an X, and oh, it ends with an X, and oh, is that Xanax? Oh yeah, right, okay. Of course, that's what they want. So they want the benzos. Oh yeah, I want that drug. It's blue pill with a little V cut out in the middle. Yes, that's Valium. That's how you know that it's Valium when you're buying it on the street. Got to have the little cutout V. That's the good stuff. So the benzos should be avoided at all, if at all possible, in people that are currently actively, in the middle of their substance use disorder. And if you are going to use them, I would say get a degree in addiction medicine or addiction psychiatry before you use them, and then use them with extreme caution. So, I mean, I'm not saying never, but it's sort of like don't try this at home. Or unfortunately, I got introduced to TikTok this past week, and I've noticed that on some of the TikTok videos, it says something like, what you see in this video has a high risk for danger, or something like that. Because one video I saw, I'm sorry, I'm going off on a tangent here, but TikTok is just sort of, it's like stupid human tricks all over again, right? Like from the 70s. It's ridiculous. But one of the things I saw was a guy that was like literally putting like food into like this alligator's mouth and then like petting its head. And I'm like, please don't try this at home. Like, I didn't understand how he was even getting away with that. But anyway, extreme caution, because using benzos in a person with a substance use disorder is like feeding food to a crocodile with your bare hand and then, thinking that you're not going to get your hand chopped off. So instead, So you're saying, okay, Dr. Chris, I can't wait 6 weeks for my SSRI to kick in. What the heck am I supposed to do with this person who's like super duper? They're so anxious that they're making me anxious in my office. So what I have turned to is lots of as needed Vistaril, clonidine, Benadryl as non-addictive alternatives. Now, some people will criticize me because they'll be like, "Oh my gosh, they're just gonna like abuse the Vistaril or abuse the Benadryl." Yes, they can abuse those, but it's definitely less problematic than overtaking or abusing a benzo. So it's lesser of two evils, right? And then I also get into my big conversations. And I mean, I'm talking about medicines today, but I get into my big conversations about what about mindfulness? What about exercise? What about taking a walk outside, et cetera, et cetera? So there are definitely things you can do for anxiety. What about getting rid of some of the stress in your life? Like all of the people that you hang out with that have active substance use disorder. You got to get away from those people. You will be less anxious if you get away from those negative people. So again, lots of things you can do about anxiety besides just take a pill, which is what the patients want. They want the easy way out. All right, so I'll spend a couple of minutes. Again, this is a humongous topic. We could talk about this for hours, but you know, we usually talk about it for 20 minutes and then discuss. So I'll spend the last couple minutes I have talking about buprenorphine and its kappa antagonism, which makes it a novel or not so novel antidepressant. Why do I say not so novel? Because from the 1850s to the 1950s, we didn't have Prozac. We didn't have any tricyclic antidepressants. What did we use to treat depression? Opium. Okay, the ultimate feel-good drug, right? Why are so many people caught on heroin? Because it makes them feel fantastic when they take it. So yes, opium was what we had to treat depression from 1850 to 1950. And we do know that buprenorphine is not only a mu partial agonist, it is also a kappa antagonist. And when you are a kappa antagonist, that has an antidepressant effect. And we have had observational studies for 20 plus years, which have shown us that low dose buprenorphine, 0.4, 1.26 milligrams per day. Think about how small that is compared to your patients that take 16 milligrams of buprenorphine a day. We know that low dose buprenorphine can improve treatment resistant depression. We even have 2 recent randomized controlled trials that looked at this drug called buprenorphine slash samidorphan. 2 milligrams slash 2 milligrams was used as an adjunct treatment of depression. It was sort of described as novel and promising candidate. Didn't do so hot. I think they, you know, they put in their drug application and then it didn't work. They have to put their application in again, but they're getting there. So there's definitely something to it. And again, in my practice, I don't know what it is, and I have to do more reading on this subject, and perhaps there are people on the phone that are a lot smarter than me that know about this, but I'm convinced that for my severely mentally ill patients, when I get to a Suboxone dose of between 20 and 24, it has a stabilizing effect on their anxiety, their depression, and a whole lot of other things that seem to be not directly addiction related. And that's probably why, if you look into my practice, me more so than other people has a lot of people on 20 to 24. Plus, I have lots of chronic pain patients. The other reason. So, anywho, I will stop there.